evening again, everyone. Thank you for joining us this evening. So this evening we'll be exploring palliative and end-of-life care. And within that, we're going to cover what palliative care is, how it can help you, think about who's involved in delivering palliative care and where it's given. And then we'll also explore end-of-life care, including what we mean by end-of-life care and how we know that's happening, and share thoughts on how to live well to the end of life. Then, importantly, we'll give quite a bit of time at the end, towards the end of the session, for you to ask questions. So my name is Rachel Richardson, and I'm one of the specialist pancreatic cancer nurses here at Pancreatic Cancer UK. I've been nursing for around about 25 years, and I've done lots of different jobs within the NHS, including caring and supporting people that have a life-limiting cancer diagnosis from the point they were diagnosed through till the end of their lives. I work predominantly on our support line at the charity alongside 6 other nurses, and I've worked at the charity now for nearly 7 years. So what we'll cover, and just it's important for us to stress before we get going that tonight we'll cover a general perspective on palliative and end-of-life care, and there will be differences based on where you live and the services that are available. However, everyone should be able to access palliative care services. There could also be specific questions that you have that are unique to your situation, and they might not be appropriate to ask this evening, or you might have things that come up after this evening's webinar and you would really like to chat those things through, and we would be more than happy to chat to you on our support line, and we'll share details of those with you, so you've got them. So as we begin, we thought it was important to highlight the different language, names or terms that can sometimes be used when referring to palliative care or are linked to palliative care. It can be confusing as different health professionals will use different words that mean the same thing. And we would say, don't be afraid to ask what a person specifically means. So the phrases best supported care, enhanced supportive care, or just supportive care can be used instead of the term palliative care, but they mean the same thing. The word non-curative is sometimes used when referring to a treatment that someone is having or is going to have. And this means that the treatment is not given with an aim of curing, but is being given to try and reduce the size of the cancer, slow down its growth, help with symptoms that the cancer is causing, and in prolonging life. So an example of this might be for a health professional to say that they are giving palliative chemotherapy. The words terminal or life-limiting refer to a person that has been given a diagnosis of a condition such as pancreatic cancer that is unable to be cured. Sometimes it can be treated but not cured. Often people will also hear the name Macmillan, and this is sometimes used as a name for a palliative care team, or perhaps people will hear the phrase Macmillan nurse. The charity Macmillan fund these health professionals, so that is why they are called this. Macmillan do lots of different things, and providing palliative care is one of those things. Prognosis is often a word that is linked to palliative care. So prognosis is an estimate of the future of someone or what their likely course of disease will be. And sometimes a person will wish to know their prognosis, or more specifically, their life expectancy at the point of diagnosis or at some point during their illness, when they feel ready to ask that, or some people choose not to talk about it. It's also important to say that some of these names will make people feel anxious or frightened, and this is completely normal. And it's normal and very common that people feel very worried if someone mentions referring them to palliative care. The word hospice can sometimes be scary or daunting to some people, as this has the association with a place where someone goes to die, but that's not necessarily the case. There's also specialist palliative care, and this is palliative care that is delivered by a team or a health professional that works with people that have a life-limiting illness all the time. So they have lots of experience and expertise and often specific palliative care qualifications. And there are two other phrases there on the slide as well: care at end of life and the last days of life. And people sometimes assume that when the phrase palliative care or some of those similar phrases are mentioned, that a person is coming to the end of their lives. End of life care is a part of palliative care, but it's not just about that. End of life care refers to the care and support given in the final weeks and months of life. So, coming on to what is palliative care. So, palliative care is active. So, a person is a partner in their care rather than a passive receiver, and it's whole person centered. Sometimes we call this holistic care, and this is care which looks after every part of you and gets to know someone as an individual. And also, when we say active, this means that the care that a person is receiving should be responsive to that person's needs, as the needs are likely to change over the course of that person's illness. Palliative care is for people living with a life-limiting illness. And it's important to say that a person can access palliative care at any point after a diagnosis of a life-limiting illness. It's also important to say that palliative care can run alongside anti-cancer treatments. So, for example, chemotherapy. It's not just for people that are not having anti-cancer treatment. Palliative care is about helping a person manage pain, other symptoms, and provides psychological, social, and spiritual support. And its ultimate aim is really all about achieving the best quality of life for patients and their families. And if we think a bit more specifically about caring for a person as a whole person, we can think about this in terms of what is known as the circle of palliative care, which you can see on the screen there. So, physical care, which is all about managing a person's symptoms of pancreatic cancer as well as possible. So, this might be things like pain, or feeling nauseous, or having digestive problems, which is very common in pancreatic cancer. It's also important that we pick up on any physical symptoms that can be treated or managed that then allow someone to live and feel as well as they can. And there are some specific examples or some common things that we come across. So, for instance, a person might develop jaundice, so yellowing of their skin and eyes. They may have dark urine or pale stools, and this is caused by a blockage in the bile duct. And some of you on the session this evening may have experienced this, or your loved ones may have experienced it. And for some people, it will be appropriate that we insert a stent to open up that blockage. Another example might be if a person is vomiting and unable to keep any food or liquids down. And this can be due to a blockage in the first part of the small bowel, which is called the duodenum. And again, this may need a stent. Another example would be for someone to have a high level of calcium in the blood, which can cause various symptoms. And really, it's about considering how well a person is, what their wishes are, um, and how we best might manage these things. Because it might not always be the right thing to intervene. Another part of the circle there is emotional and psychological care. So this is for the person and also their family members, and considers how everyone is coping and exploring the impact that the diagnosis is having on everyone, and thinking about what help and support is needed within that. Spiritual care, often someone living with a life-limiting illness and their family members will begin to question the meaning of their life. And some people may have religious and spiritual beliefs. And the aim of palliative care in this sense is really to help someone reach a place of comfort and acceptance where those beliefs can be a source of support rather than a distress. A person's culture can influence how they and their families make decisions about their care. And it's really about understanding what is important to them and responding and working with that. And also social care, so thinking about how we can best manage things and support someone to remain at home if this is a person's wish. Or if not, there are other options as well within that. So hopefully by going through what palliative care is, people can see that the involvement of palliative care should be a positive experience. And there are often myths and misunderstandings that surround palliative care, and we've mentioned some of them already. So palliative care, people can think is just about end of life care, or it means doing nothing, or is the thing that happens when treatment ends, or when active treatment is not right for someone. So sometimes it can be seen as a negative. If a person's treatment has come to an end, they may feel abandoned, or that people don't care about them anymore. But people do care, and palliative care can often be very helpful in that transition. And people may worry that palliative care may involve them having forced conversations about plans for their future and preferences, and having less control over their care. And these conversations are part of it, but only at a time that is right for the person. But really, these conversations give a person more control over things and allow people to hopefully feel empowered. And palliative care can help people achieve personal goals, things that people still want to accomplish. And people may feel frightened, daunted, and very uncertain about their future, what will happen, and have lots of concerns, fears, and worries. And it's the hope that palliative care can work with a person, get to know them as an individual, what is important to them, what gives them meaning, and help them work through their fears, bringing life and hope. And it's also, as we've said, about responding to changing needs and feelings, so navigating through things together. One of the important things to point out is that ideally engaging with a health professional that provides palliative care early on is best. And this is something you can ask for. And it can be helpful in many different ways. So as we've said, in managing pain, we know that early intervention in managing pain can be really beneficial and effective in getting on top of somebody's pain. It can also be very beneficial for people to think about their own personal preferences and priorities and have conversations about these. You may have heard of something called advanced care planning. And just very, very briefly, advanced care planning is a way to think ahead and to describe what's important to you and to ensure other people know your wishes for the future. And it's about helping you to live well right to the end of your life. So thinking ahead, discussing with others, and writing things down means that your wishes are known and respected, and you're more likely to receive the kind of care you want and be in the place you choose. And if you were to become unwell, or if you could no longer speak for yourself, these things have been shared and recorded. So if we think about who delivers palliative care, the palliative care can be delivered by any health professional who provides care to a patient. So a couple of examples are the GP or the district nurses or community nurses. And as we've said, there are specialists that work with people that have a life-limiting illness all the time. So they have a lot of expertise, a lot of knowledge in palliative care. So sometimes you might hear of a specialist palliative care team. And specialist palliative care really has its background in the hospice movement. So often the words specialist palliative care and hospice go together, or they're used interchangeably, but they do mean the same thing. So your local palliative care team may come from a hospice, and it may be that they provide the palliative care in the area where you live. And as well as a hospice building that you can visit or stay at for palliative care, they may have staff that see people in their own home. There are also specialist palliative care teams in hospitals, and again, people may have experienced input from them, and they may see you if you're admitted to hospital. And it's really dependent on a person's needs and what services are available, if they will be seen by a health professional that provides general palliative care or by a specialist palliative care team. And there can be lots of different health professionals in a palliative care team. So, for instance, an occupational therapist, a physiotherapist, nurses, doctors, social workers, and professionals that provide specialist advice, for instance, regarding finance and benefits. And hospital teams, as we've said, can provide palliative care. So often they work alongside other health professionals. And this is particularly relevant if somebody's having anti-cancer treatment. Or as we've mentioned before, often it will be a mix of health professionals. So sometimes involving the hospital team is necessary if we're thinking back to what I was saying before about if somebody has jaundice or a blockage in their bowel. So often it's about that cross-team working. And it's also important to say that the GP is still there and their involvement is very important. And I've also mentioned there Macmillan and also Marie Curie that can be involved in someone's care. And I think it is really important to be clear of people's roles, so who they are, what their role is, and how they link in with other people involved in your care is important to ask about, because communication and linking up care is really key. And palliative care can be delivered at home. It can be delivered in hospital, as we've said, or in a cancer centre, or in a hospice, or in a care home. So just thinking about when someone from a palliative care team comes to see you, what can you expect? What can they offer you? And again, we're speaking quite broadly here. As we've mentioned already, palliative care is centred on getting to know someone as a whole and as an individual in order to know what's important to them, in order to maximise their quality of life. And thinking back to that cycle of palliative care, the physical, social, spiritual aspects. So the first visit from palliative care can sometimes be quite detailed as they begin to get to know you. Open and honest communication is something to expect, and this shouldn't be forced, but it can be very important for lots of people to understand their illness and expectations for the future. And if a person wants this information, then it's important that this is provided in an honest, empathetic way, recognizing that these conversations can be difficult. So it's good to think about what information is important to you. So you can write down questions in advance that you would like to ask so you don't forget them. And we would say difficult questions are usually better asked. It's also important that loved ones are able to ask their own questions as their needs may be different. And often palliative care health professionals are able to facilitate those difficult conversations. This can then lead to an offer of planning for the future. And ideally, as I've mentioned, the earlier the better. And doing this at a time when someone is well enough to think about these things. So, for instance, perhaps planning for a predicted deterioration in someone's health in the future. So, for example, where a person wishes to be at the end of their lives, if they want to go to hospital for treatment, if certain things happen, or financial planning. And if we don't know someone's wishes, then we can't honour them. Working together to try and resolve or improve things in terms of the present and the future. And in order to do this properly, then honesty and openness about the struggles someone is having is key to that. And this might mean involving other services, for example, counselling or organising equipment or practical care. And there should be follow-up plans made based on what has been talked through, planned and agreed. And how often a person is seen will really depend on what is happening with them and their condition. And ideally, plans should be shared with other health professionals that are involved, for example, the GP. And a person should be given contact details, in-hours contacts and out-of-hours. And if there is a change in a person's condition, then it's important that someone lets the palliative care team know, and then appropriate steps can be taken. Okay, so that's my bit done. Yeah, and I'm gonna pass over to Simon now.
Thanks, Rachel. That was really informative. Thanks very much. I'm going to take you through to the end of the webinar. My name's Simon. I've recently joined Pancreatic Cancer UK. I work on the same team as Rachel. My experience is largely working as a palliative care specialist nurse within a hospice and community setting. We recognise, as we said at the beginning, that this part of the talk may be upsetting and too much for some of you. So we're going to have a short sort of minute or so break, so that if you want to leave the webinar, you can. Feel free to join us again for the Q&A in about 20 minutes or so time. But we'll just break for a minute now, and then I'll come back and we'll start the next session. Okay, I think we'll start now, if that's okay, because just mindful of the time. So Thanks for joining for the second part of the webinar, where we'll continue to explore what we mean when we talk about end-of-life care, and more specifically the last days to weeks of life. I'm just going to share a graph with you which I hope illustrates what can happen at this stage and why it's good, as we've already said through Rachel's session, to be prepared. Okay, my apologies that this slide is a little bit clinical. It's proved difficult to find something that's a bit more user-friendly, but hopefully it will get the point across. As you can see from the graph, generally speaking, deterioration from advanced cancer is experienced as a relatively rapid decline over a short number of weeks as compared to other illnesses. It's fair to say that this is not always the case. It can be slower, steadier deterioration, have ups and downs, as well as sometimes happening much quicker than we can anticipate. This graph also illustrates why it's important to engage with palliative care services earlier on during the relatively stable, sort of functionally independent periods, to allow enough time for their input to be of maximum benefit to you and your loved ones. The graph could give the illusion of simplicity and predictability in situations which are sometimes the exact opposite. However, it does illustrate what we as health professionals often see as a sort of general trend. This can also suggest that it should be relatively easy for health professionals to predict time or prognosis. However, this is not the case. It's notoriously hard to predict time at the end of life, and we as professionals often get it wrong. There are indicators and changes which can help give us an idea of how much time may be left, and these are used to try and gauge what a person's prognosis might be in terms of months, weeks, or days, but this can never be predicted with pinpoint accuracy. Often the most useful way to try and gauge things is to look at the speed of change in a person's condition. So relatively slow change over weeks would suggest a prognosis or time ahead in the order of weeks. Daily deterioration would suggest days into maybe a week or so, whilst change seen hour by hour might suggest time measured in hours to days. In my role, I've been asked many times, how long have I or how long have we got? And whilst I'd always give an honest idea, I would also ask, why is it important for you to know the answer? This may seem a ridiculous response when the reason is obvious, but it's meant to reframe the question and refocus attention on what's important and how we can achieve as much as possible in whatever time we have left. And this can be a far more productive way of looking at time rather than seeking a number, which can cause so much distress if we've over or indeed underestimated the amount of time left. So what can I expect to happen in the last week or so of life? Severe fatigue, reduced in daily activity, sleeping more and more. We often see this, and it's people struggling to do even what they would see as very simple things like walking upstairs or making a cup of tea can become really difficult, and they're spending more and more time either asleep in bed or resting in a chair. And the rest that they do have, even if they sleep for 20 hours, isn't restorative. They wake up just as tired as they did when they went to sleep the night before. It's normal for eating and drinking to wane and for you to have less of both, and also to see significant weight loss. Being unable to concentrate, occasionally you might see some confusion or agitation at this stage. And that inability to concentrate is linked to the fatigue. And what you can find is that conversations can become hard to follow, particularly if it's several people talking at once, or you might no longer be able to watch your favorite TV program or read a book because you just don't have the energy to do those things. Sometimes that can be interpreted as somebody withdrawing. It's not necessarily the case. Sometimes they're just exhausted. You can sometimes see swelling in the feet, legs or hands, and also in the belly, which is called ascites. There are times when ascites can be drained, but not always, and that's something that you'd be guided by with your medical team and your nurses. There is a rare risk of bleeding with pancreatic cancer. This is because of where the pancreas and the organs around it sit in the digestive system. It is rare, but it's something for you to be aware of and to discuss with the doctors and nurses looking after you so that you know how this can be managed if needed. These changes can happen slowly or over several weeks or more rapidly, and sometimes with little warning. As Rachel discussed earlier, if we see a rapid and unexpected change in a person's condition, even if they have an advanced disease and a likely short span of time ahead, we should still consider investigations to rule out reversible causes, so things like infection or perhaps severe anemia. However, as we get closer towards the end of life, this should only really be considered if it's firstly what you want, but it's also clinically appropriate to do so. By this, I mean there needs to be a clear benefit to you within the most likely amount of time we have ahead. And for example, at the end of life, blood tests can be really skewed, and this can trigger hospital admissions in cases where there's nothing realistically to be achieved by that. Just because we can perform tests doesn't mean that we should. In pancreatic cancer, managing conditions such as insulin-dependent diabetes is also really important, and you'll get support from that from your doctors and nurses, and that's to avoid unnecessary symptoms or complications. Once it's clear that someone's entering the final stages of their disease, then the doctors or specialist nurses involved will usually discuss stopping unnecessary medications, and that's to avoid tablet burden. And they'd also talk about stopping unnecessary investigations like blood tests or blood pressure, pulse, those kind of tests. At this stage, if not already discussed, it would be appropriate to have a do not attempt resuscitation form in place. So that's DNA CPR, DNR, sometimes referred to as RESPECT form. And here, when we talk about DNA CPR, what we mean is that we're not going to attempt to keep someone alive at a point when they are naturally dying. And the attempt would not only be futile, but also traumatic. Having a DNA CPR in place doesn't mean that all active care stops, and it's important that you know that it will continue where appropriate, for example, if we're treating things like infections. And there will be a link in the chat to the NHS website with more explanation around how DNA CPR decisions are made if you'd like to look at this further. Symptom management is a big part of palliative care at the end of life, although this doesn't mean that difficult symptoms are inevitable, and that can often be a fear of people that as they come to the end of life, everything just gets worse, and that's not always the case at all. We should, however, be prepared, and this is why, just in case, injectable medicines are often prescribed in advance. There's usually 4 drugs, and these will include medications for pain, so things like morphine or oxycodone, depending on what you've been using in the past. Anti-sickness drugs, something for respiratory, so that's your chest secretions, and also things for agitation. These need to be prescribed and available in advance to avoid crises in out of hours. The last thing anyone wants should you develop symptoms at 2 a.m. on a Sunday morning is that we've nothing available to help. These medications are made available if needed, however, and are not meant to be given routinely if there are no symptoms present. When we talk about injections, we're talking about subcutaneous injections, and that means it's under your skin rather than into a vein or a blood vessel. And they're necessary when someone can't swallow, or they're not absorbing the medications properly, or they've got nausea and vomiting. And these injections will be given by a nurse. If multiple injections are needed, then it would be normal practice to start a syringe driver. A syringe driver is a small automated pump which administers the medication under your skin, and it goes over a 24-hour period, and this will be monitored and changed by a nurse. It's important to note here, though, that in and of itself, a syringe driver is not an indicator that a person is imminently dying. These machines are often used much earlier to manage symptoms like nausea and vomiting, things like chemotherapy. If you've been taking regular pain relief by mouth, such as morphine or oxycodone, or regular anti-sickness or things for agitation, then these drugs would need switching to a syringe driver to avoid your symptoms recurring. Medications are not the only ways to manage symptoms, and I'd encourage everyone not to see them as a fix-all. Non-drug techniques can be really helpful and sometimes better than medication. And in this, I mean anything from your time with your pets, time outside, music, distraction therapies, massage, aromatherapy, VR, anything that will enable you to step back away from whichever symptom you're trying to manage. We can also see yellowing of the skin and the eyes, which is jaundice. So some of you may already have experienced this. So what can I expect to happen in the last hours to days? Sleeping to the point of not waking up and no longer being conscious. When this happens, positional change, so the person being helped to move, is really important because they're no longer able to do it themselves. Sometimes it can feel cruel, or you wonder why somebody's being moved when they look really comfortable, but it's because changes to your skin can happen very quickly, and then that can cause all kinds of problems with things like pain. So that's why your nurses and carers will often make adjustments to position. You can experience noisy and or altered breathing. Noisy breathing is caused by secretions which pool at the back of the throat. You or I would normally clear them and swallow them without even thinking about it, but when you're very weak, it's not possible to do that. And this can cause loud rattling noise as each breath passes through those secretions. It's often more distressing for those hearing it than the person themselves. And a simple change of position can be enough to clear this, but there are also medications available if needed. Sometimes the breathing can change. It can become shallow or rapid or heavy or slow or a combination of these things. Again, this is often not distressing for the person themselves, but it can be difficult if you're not aware of it to witness. We'd expect that your appetite would go, no longer eating and drinking, and usually that's because as you become weaker, your swallowing becomes harder and to the point where it's not safe. Not eating and drinking can be a worry, particularly for loved ones concerned that the person may be hungry or thirsty. As we come to the end of life, our body's need for and ability to handle food and fluids reduces, and they are no longer required in the same way. For most people, supplementary fluids, and they're usually given under the skin at this point rather than into a vein, are not necessary, and comfort can be maintained through good mouth care. And as loved ones, you can be involved in this with support from the nursing team. There are trials ongoing around the potential benefits of giving fluids at the end of life, which you may come across. In most cases, like I said, it isn't necessary. And for some people, extra fluids can cause more problems because it causes increased swelling and more fluid on your chest. So your medical team would be able to discuss this with you if it was something you wish to explore. You can also see changes in skin colour, so it can be sort of dusky grey or bluish or mottled, particularly to the hands and the feet. It's not unusual to have cold and hot flushes, and that's because your body is struggling to maintain its temperature. Sometimes you'll see jerking or twitching movements. They don't always mean anything to worry about, but again, it can be unnerving if you're the person caring and seeing these things. But in most cases, just slight jerks and twitches don't mean anything, and the person will be comfortable. If you're at all uncertain, ask the nurses and the doctors caring for you. And towards the end of life, confusion and agitation again can be an issue. Sometimes visual hallucinations can occur, but the medications are there to help, and you've got the doctors and nurses as well to support you. General care at this time is really important. And by that, I mean keeping people washed and clean and respecting their dignity, but also looking after things like their bowels and their bladders. And one of the reasons why the nurses will constantly check this is because if you need to move your bowel or you need to pass urine and you can't, that can cause lots of agitation and distress, and it's usually a very simple thing to manage. Once it's felt that a person is in the last hours to days of life, it would be normal practice for an individualised end-of-life care plan to be discussed. And this plan should cover your physical needs, so your symptoms, fluids, personal care, dignity, respect, but also any psychological, emotional, spiritual needs. And that includes the needs of your family and loved ones. So, where, who, and what? Where do you wish to be? Sometimes your preference for place of care may change for many different reasons, and it's important to continue to talk openly about where you wish to be. Discussions prior to this stage can be really helpful in informing decisions made on your behalf should you become confused or unable to express your wishes, and that's part of the advanced care planning. If it is your wish to be cared for and to die in a place away from your home, such as a hospice, hospital, or nursing home, then this is the time to begin to plan the move to that place. Discussion and planning shouldn't be left too late, particularly as beds in places like hospices or nursing homes may not be available at the last minute. If your decision and your preference is to stay at home, then considering everyone should also include any children or grandchildren. How and indeed if children are to be involved in the last days of your life is a very personal issue. Palliative and supportive care teams will be able to advise you if you're uncertain what to do, and often have access to resources to help with potentially difficult conversations. From my experience, children are often far more aware of what's happening than we realise, more resilient and able to cope than we give them credit. And also being involved at this stage can be a real benefit for them in the future. The who really is anybody who is special to you, anybody that you feel you want to connect with for whatever reason. It's seizing the moment and using the time that you have. So this could be spiritual leaders, people you've perhaps not been in contact with for a while. The what includes anything important to you as a person in your life: art, music, film, nature, particular clothing or bedding, anything which gives peace, enjoyment or comfort. And these are things which can also be important ways for those close to you to feel connected. For example, watching a favourite film or listening to music together. You probably already will be in contact with at least district nurses, community nurses and your GP at this stage, but it may also be that you, if you haven't already, that you need input from specialist palliative care services, particularly if you are beginning to develop symptoms. But there are also carers and charities like Marie Curie who can be involved at this stage if you need. We do need to consider practical things, so that's having the right bed, the right mattress, considering whether you want to be upstairs or downstairs in your home, having equipment to aid movement and independence for as long as possible, and that's things like commodes or toilets and equipment for the bed, including continence pads. And your community nursing team will help you with these issues. And as we keep saying all the way along, it's best to plan ahead and have these things in place slightly before you need them. Remember that 24-hour supportive care at home is highly unlikely. So you do need to think ahead if you're going to need a lot of support. There are different agencies which can help, but this will need planning and coordination, and the palliative care team, district nursing team, GP will help you with this. Charities such as Marie Curie can provide some support. However, this will usually need organising via a community nurse and may not be possible in your area. This might sound obvious, but check that the contact numbers you've been given actually work, and which ones are likely to go to an answering machine and at what time. It can be really stressful if you call in a crisis expecting to speak to a person but instead get an answer phone message. It doesn't mean your message will be missed, but it will help if you understand and know how often those messages are checked and by whom. Okay, so I guess this is a bit of a summary from Rachel and I in terms of the points we'd like you to take home. So how can I live well until the end of my life? Don't be afraid of palliative care services. They can make a big difference. Like the rest of your life and your experience of living with cancer, the end of your life will be unique to you. And whilst there are things we can reasonably expect to be universal experiences, there's no easy protocol to follow. What is important is that this time is precious and you can still experience joy, love, laughter, and happiness, even during a time when this seems impossible. This experience can touch on every aspect of your personhood and those around you, and there's no way of knowing how it will be. Sometimes you'll need help. Professional support at the end of life can involve many different agencies, as we've seen. And it's better to engage with palliative care and supportive care services earlier rather than later, and at a time when they can be most useful to you. Be honest about what you want, and we've got one chance to make this as good as it can be. Open and honest communication as soon as you feel able to engage will give you the best chance of meeting your wishes. Having conversations about end of life, death and dying and not giving up. They're more an acknowledgement of what is happening and are seeking to regain and maintain as much control as you can for as long as is possible. Stating what you do and don't want will include things like investigations, treatments, hospital admissions, and anything which you feel important. But remember, you can change your mind. As Rachel was saying, advanced care planning is the way to summarise your wishes and make sure they are known to those caring for you. Your wishes should be respected regardless of your sexual orientation, gender, religion or ethnicity, or any other group, belief or expression you identify with. Your community nurse, GP, and certainly your palliative care team will help you with your advanced care planning. And in my experience, it's often best to plan for the worst whilst aiming for the best. I would mention here that if you're thinking of looking for a lasting power of attorney and that's important to you, just be mindful that it can take 8 to 10 weeks for that to be granted. So that is something that you do need to plan ahead well for. It can be difficult to say it as it is. So if you do need help, ask. It's good to talk together with those close to you, but also to have the opportunity to speak with someone separately. Even in the closest relationships, sometimes the need to protect each other means we don't always have an outlet for what we're really thinking. Talking with a professional you trust can provide a safe space in which you can say exactly how you feel. I've spoken of the importance of communication. However, I do want to stress that this is not enforced and that no one should ever feel that they have to talk if they don't want to. I've supported people who wanted to talk often and about everything, but I've also looked after people who didn't want to talk at all, and then everybody else in between. Whatever works for you is fine. This is your journey, and the last thing any professional would want is to make it any more difficult for you to navigate by forcing you to have conversations that you don't want. There will be differences in care provision across the UK, and it can be really helpful to know in advance what is and isn't available where you live so that you can match your expectations to reality. And as Rachel was saying earlier, there are links in the chat to Hospice UK, Macmillan and Marie Curie where you'll find more information. If you're caring for someone at the end of their life, it's vital you also look after yourself. If you are caring for someone, this can be a tough thing to do. And I've heard many times people express that even if they felt ready and prepared to care for their loved one, they found it much harder than expected. It's hard to prepare for the reality of what's to come, even if it's relatively free of major incidents. It can be physically and emotionally exhausting, particularly if you don't have much support. So I would encourage you to seek and accept help. Take breaks, take time out for yourself and recharge. This time is precious and can have a big impact not only on the person who is now dying, but also those who remain when they've gone. The effect of what happens during this time will resonate into the future, which is another reason, if one were needed, to make the end of a person's life as good as it can be. Bereavement is a natural consequence of death and something we will all experience in our lifetime. To be able to look back on this time with some positive feelings and special memories can be a powerful way of helping the process of grieving, as well as keeping a connection with your loved one which transcends pancreatic cancer. Thanks for listening. I hope that's been helpful. And we now have some time for a Q&A. So thank you, Suzanne. Asking about itching that you found difficult to tolerate and severe, and despite the bowel duct stenting, it was still, you couldn't find relief. So what are the things that we can do? There are creams sometimes that help. Menthol creams can be really useful. They are, I think they're prescription only, but if you speak with your district nurses, they would be able to advise on that. Using cold water to wash with sometimes can help with the itch as well. There are certain medications which can help. I'm loath to kind of advise really, because it does depend what other medications you're taking, and it's like this, which is really not responding, would be a good reason to have your palliative care team involved, because these are the kind of complex things that they would look out for. So we've got a question around secretions in the mouth at the end of life, and what we would do. Sometimes if you can reach them, sometimes you can use a soft cloth to remove those secretions, but if they're right at the back of the throat, you can't. But a change of position, so rolling from side to side, can sometimes dislodge those secretions and move them. If that doesn't help, then depending on where you live and who's done the prescribing, there are usually two drugs. One's called hyoscine, and one's called glycopyrronium, and they're both injections, and they can be helpful with secretions. Okay. So we've had Robert, who's had chemotherapy and radiotherapy, and now second bout of chemo, and had a collapsed lung. Okay, suggestion for a fortnight of steroids.
Give me a shout if you want me to answer any.
Yeah, go for it, Rachel.
Shall I offer some thoughts, and you can always chip in?
Yeah, sure.
Yeah, I guess so steroids are very commonly used. Often they can be helpful in a number of different ways. So they can be helpful with pain. They can be helpful with nausea, and vomiting. They can also help to boost appetite. So usually when someone's given a course of steroids, we use a drug called dexamethasone, and they're very commonly used for patients that are undergoing chemotherapy. So people take them just for a short amount of time when they're having chemotherapy, just to help manage side effects. But they can be used outside of chemotherapy as well for those reasons that I've just said. So they are used on a short-term basis, and usually they would start at a certain dose and then reduce. So we call it a sliding scale. And the reason why they're not given over a longer period of time is they do come with side effects. So it's important to that they're only given for a short period of time, and that we monitor things closely. But they can be beneficial for patients. So I'm sorry to hear that you're going through a really difficult time, and but yeah, they may be helpful for you, Robert.
We've got a question asking, is the first port of call a local hospice or Macmillan? I'm assuming that's for palliative care services. It depends where you live. Quite often, as Rachel said, community palliative care is often provided by hospices, and they have a community team that will go out to you at home. You may also have Macmillan input from hospital, which can support you at home. It really does depend where you live, but if you're at home, your district nurse will be able to put you in touch with the palliative care team, or indeed your GP. I hope that answers your question. If not, please add to it, and I'll do what I can to add more. And we've got a question asking, can a person still hear at the end of life when dropping into a coma? I guess the short answer is we don't really know. There is a belief that hearing is one of the sort of the last senses to go. I would suggest, regardless of what we do or don't know, that I always encourage people to keep talking to their loved one, keep involving them. It can be hard when somebody's not replying to what you're saying, but keep them involved when you're chatting together, and assume that they can hear, and then they are involved in your interaction. Okay, we've got a question asking, is diabetes common? That's going to be difficult question to answer, I guess, in this meeting, because yeah. I'm not sure if you've got any answer on that one, Rachel. I think it's going to be a difficult one to answer, really.
So diabetes within pancreatic cancer is common. So often diabetes can occur as a result of somebody having a pancreatic cancer. If we think about how a pancreatic cancer impacts the way that the pancreas works, so diabetes can occur as a result of that. So it is very, yes, it is common, and it's important that people who have a diagnosis of pancreatic cancer are monitored for diabetes, because it can develop over the course of a person's illness. Sometimes people have a diagnosis of diabetes before their diagnosis, and sometimes that might not be the correct diagnosis, or it's diabetes that's actually occurring as a result of the cancer. So yes, to answer your question, I would say it is common, or perhaps somebody that has type 2 diabetes may notice that their blood sugar control that has always been quite good suddenly becomes quite difficult and challenging and erratic. So.
Thanks, Rachel. We run out of time, unfortunately. There is a question around moving from home to 24-hour care with some quite difficult symptoms. And I think I'd encourage you to, that's perhaps a question you could send to us via email, and we can go into a lot more detail with you, or even if you felt comfortable ringing the support line, we could chat through that one. It's not an easy question to answer quickly, and it wouldn't do it justice if we tried it now. So thanks, everybody. Thanks again for joining us, and I hope that's been useful. We're now at the end of the event. I hope it's been helpful. And as we've mentioned this evening, there's lots of useful information available to order or download on the Pancreatic Cancer UK website. And this includes what to expect from your care, symptoms towards the end of life, and also emotional support, as well as lots more. So thanks again, everybody, for joining us. Take care.